bacteria. So let us learn about them today. The learning objectives of the class are, at the end of the session, you should be able to describe the morphology of this bacteria, know its antigenic structure, describe the pathogenesis and the clinical manifestations of these bacteria, and you should be able to know the list of laboratory diagnostic methods, choose the appropriate test and interpret the results. At the same time, you should be able to describe the prevention and treatment of the disease caused by this pathogen. So looking into the general characteristics of this bacteria, it's the smallest free living bacteria, about a size of 0.1 to 0.2 micrometers. It can pass through the bacterial filters. Usually the pore size of bacterial filters is 0.45 microns, through which the bacteria can't pass. They're retained on the filter membrane, but Mycoplasma are too smaller than this size, so they can pass through the bacterial filters. They are cell wall deficient forms. So are they L forms? Let us discuss about this in subsequent slide. They have a cell membrane which is packed with sterols. They do not possess any spores, flagella or fimbria, but yes, some Mycoplasma species exhibit gliding motility. They glide through the host tissues. They have a very slow growth rate. That is, they have a longer generation time, the generation time of 6 hours. So the time taken to grow on the culture media is somewhere around 1 to 3 weeks time. They are cell culture contaminants. Cell cultures or cell lines are usually used to grow viruses. So these Mycoplasma, these bacteria can contaminate the cell lines used to grow the viruses. So it's a very important MCQ. They might ask what identify or mention the cell culture contaminant. So the cell culture contaminant, one of the cell culture contaminant is Mycoplasma pneumoniae. Now let us see about the L forms in Mycoplasma. So regarding the cell wall, Mycoplasma inherently they do not have a cell wall, whereas L forms they have a cell wall which is lost either spontaneously or by action of some antibiotics. You already know about protoplasts and spheroplasts. So Mycoplasma inherently doesn't have the cell wall, whereas L forms can revert back to the original form. That is, they can get back their cell wall when the conditions are appropriate. That's why they are called unstable forms. Coming to sterol requirement, Mycoplasma requires sterols for their growth, whereas L forms do not. Mycoplasma are filterable through the bacterial filters, whereas L forms are not filterable. Mycoplasma cause variety of respiratory and genitourinary tract diseases, but L forms as such do not cause or initiate any disease. But yes, they play a very important role in persistence of chronic infection, because they can't be active. If you are using a cell wall inhibitor antibiotic, it doesn't act on these L forms, and they can remain, they can have a role in persistence of chronic infection. Looking into the classification, they belong to class Mollicutes. It's a Latin word. Molli means soft and cutes is skin. So they belong to family Mycoplasmataceae, which includes several genera, but let us remember 2 genus, that is Mycoplasma and Ureaplasma, which includes variety of species causing human diseases. So among this, let us mainly remember 4 species. One is Mycoplasma pneumoniae, which causes respiratory tract infections, and other 3 are Mycoplasma genitalium, Mycoplasma hominis, Ureaplasma urealyticum, which cause genitourinary tract infections. Now let us learn about Mycoplasma pneumoniae. Why is it called Mycoplasma? Myco means mycology is fungus. So why it's called Mycoplasma is the first Mycoplasma species which was isolated from the cattle, which wherein it caused pleuropneumonia. It was Mycoplasma mycoides, which has a colony morphology resembling, which had a fungus-like colony morphology. That's why it had obtained that myco in its name, and plasma denotes the plasticity of their shape. They're very pleomorphic, these bacteria. So hence the name Mycoplasma. They're also known as pleuropneumonia-like organisms, and Eton agent from the scientist who had cultured this bacteria. It's known as Eton agent after the name of the scientist who has cultured it. It's a strict aerobe. It colonizes the nose and the throat of the humans. So it's easily transmitted to other humans with the help of by the nasal secretions and aerosolized respiratory droplets. So wherever there is a large group of people, like in schools, a large gathering of the people like military recruits, this bacteria can be easily transmitted. Now let us look into the antigenic structure. The antigenic structure includes cell membrane antigens mainly. One is the glycolipid antigens and other is the membrane protein antigens. Glycolipid antigens are very non-specific. Why non-specific? Because they show antigenic similarity with certain other bacteria as well as cells. So they form a basis for heterophile agglutination tests. We'll be talking about them in subsequent slides. And looking into the protein antigen, the P1 adhescent protein is very helpful for the mycoplasma to attach to the respiratory epithelial cells. Now let us look into the pathogenesis. The transmission is by inhalation of pathogen droplets. Once inhaled, it attaches to the respiratory epithelium by P1 adhescent protein and they damage the cilia and the ciliated epithelial cells. So the mucociliary mechanism is lost and the bacteria can easily enter the lower respiratory tract where it affects the lungs. And the local inflammatory response in lungs is because the bacteria already acts like a super antigen. So it stimulates migration of inflammatory cells and it causes massive release of cytokines. If you remember, super antigens cause non-specific activation of T cells and massive release of cytokines, which rather than protecting causes lot of tissue damage. Apart from this, it also produces cytotoxin which damages the lungs. So now, having known about the pathogenesis, let us look at the clinical manifestations. So pulmonary manifestations it causes are pharyngitis, tracheobronchitis and pneumonia. The pneumonia here is known as atypical pneumonia. Why? Because usually in bacterial pneumonias, the clinical picture is like high fever, dyspnea, chest pain and productive cough. Whereas in mycoplasma, the picture is different. There is mild fever, just a sore throat, dry cough and fatigue. So it's something different from the picture of a typical pneumonia. That's why it's known as atypical pneumonia. It's also known as walking pneumonia because the patient initially is not very sick. Usually the patient with pneumonia is very sick and is bedridden and brought to the hospital. But here the patient by himself walks into the OP. So it's also known as walking pneumonia. It's known as community acquired pneumonia. Already we have discussed it's spread through the nasal secretions in places where there's huge gathering of gatherings like schools and military recruits. So hence it's known as community acquired pneumonia. It's not a hospital acquired pneumonia. It's known as interstitial pneumonia because rather than alveoli being affected, it affects the interstitial spaces of the lung. Hence it's known as interstitial pneumonia. So in usual pneumonias like pneumonia caused by Streptococcus pneumoniae, the picture is different. There is high grade fever, chest pain, dyspnea, and there is alveolar pneumonia with productive cough. But the picture in case of Mycoplasma pneumonia is very different and hence it's known as atypical pneumonia. Looking into the extrapulmonary complications it causes meningoencephalitis, cerebral ataxia, it can cause pericarditis, it can cause coagulopathies, hemolytic anemia and variety of mucocutaneous lesions. So talking about mucocutaneous lesions, let us look into one, Stevens-Johnson syndrome. So you must have studied about Stevens-Johnson syndrome. Usually it results after, it is seen in certain patients after use of certain drugs like use of sulfonamides, allopurinol, antipsychotic drugs, etc. But this manifestation, that is Stevens-Johnson syndrome, was also seen following Mycoplasma infection in certain individuals where there is diffuse rash all over the body which can turn into blisters and even results in death. It's an immune complex mediated disease which shows these mucocutaneous lesions. Now let us look into other agents which cause atypical pneumonia apart from Mycoplasma pneumoniae, Chlamydophila pneumonia, Chlamydia psittaci, Legionella pneumophila, Coxiella burnetii, adenovirus infection, influenza virus infection, all these also cause atypical pneumonia. Okay. Now let us move on to the diagnosis. If you look at the samples to be collected are, because it's colonizing the throat and the nose, the throat swab, nasopharyngeal aspirate, bronchial washing, bronchoalveolar lavage, sputum, blood and CSF. If it's a neurological manifestation, you can also collect the CSF. But for the culture, sputum is not very preferred because there are several commensal flora coming in the sputum along with the pathogen. So if you look at the processing, how do you process? Either by culture, antigen detection, antibody detection, that is serology, and PCR. So the best diagnostic method is molecular method, polymerase chain reaction. It is most sensitive and specific. Looking into the culture media used is pleuropneumonia-like organism agar, pleuropneumonia-like organism broth, diphasic media having both agar and broth, or sp4 media. What is the speciality of this media? They have ingredients like beef heart infusion. They have serum, that is bovine or horse serum, which is providing sterol or cholesterol to the mycoplasma. They have yeast extracts which are providing nucleic acid precursors, and they have certain selective agents like penicillin, thallium acetate, certain other antimicrobials like amphotericin. So all these, what do they do? Penicillin a little bit bacterial, other commensal floral growth. Amphotericin will inhibit the growth of fungi and so on. So once you put inoculate the sample onto the culture plate, you have to incubate at 37 degrees centigrade, and you have to wait for almost 1 to 3 weeks to see the growth. In liquid media, the growth, how does the growth look? The broth becomes turbid and there is color change. Why there is color change? Because this bacteria will utilize glucose and will cause the change in the color, which is indicated by phenol red. This point, fermentation, please rectify it. It rather utilizes glucose. Okay. And then on the solid media, how do the colonies appear? They appear like mulberry. So you can see in the picture how the mulberry looks. So the colony also appears the same. These colonies are very small. They are just 200 to 500 micrometers. It's very difficult to see with the naked eye. We have to use a microscope, or we can see through Dine's method. Now don't confuse this Dine's method with Dine's phenomena, which you have heard in Proteus infection. It's different from the Dine's phenomena. In Dine's method or Dine's stain, you cut the block of agar containing the colony from the culture plate, place it on the slide, and then you stain it with alcoholic solution of methylene blue and azure, and you see it under the microscope. If you can look at this picture here in the slide, it appears like a mulberry colony. So you can see that it's typically looking like a mulberry colony. Okay. So this is another photograph showing that. The next slide, which is showing the Gram stain and Giemsa stain. Because it's cell wall deficient, it doesn't look very peculiarly like a cocci or bacilli. It has some signet ring appearance. So, but what is important is the picture D showing mulberry-like colony of Mycoplasma pneumoniae, and picture C showing fried egg colony of Mycoplasma hominis. Now once it has grown on the culture plate, it has shown mulberry-like colony. We need some more identifying features to say it is Mycoplasma pneumoniae. So how do we do that? We do with the help of hemadsorption test, wherein when you add the guinea pig RBCs to the colony of Mycoplasma pneumoniae, they adhere to the colony. Next is when you add a ditetrazoleum to the colony, the color changes from the colorless, the dye being colorless, it is reduced and it becomes red in color. Next is growth inhibition test, which is done by adding specific antisera. Okay, so the growth of the colony is inhibited wherever you place a disc impregnated with specific antisera. So this was about the species identification. Now after the culture, let us move on to antigen detection. And antigen detection is with the help of direct immunofluorescence test and antigen capture enzyme immunoassay, wherein you are detecting the P1 adenosine antigen in the clinical sample. You can place the clinical sample on the slide and then add a fluorescent tagged antibody specific to it and look under the fluorescent microscope, or you can use a rapid test like enzyme sandwich ELISA. The test is complete in just 10 to 15 minutes. Next, let us move on to antibody detection, that is serology. There are specific tests and non-specific tests in this. The specific tests includes ELISA and immunofluorescence, where you can detect antibodies by 1 week of illness, and you can individually detect IgM and IgG, so you can differentiate between recent and past infection. Coming to non-specific tests, we already discussed the glycolipid antigens of Mycoplasma pneumoniae have antigenic similarity with certain other bacteria and cells, certain other bacteria like group F streptococci known as streptococcal Mg, and they have antigenic similarity also with human O blood group RBCs. So they are known as heterophile agglutination tests. There are two of them, one is streptococcal Mg test and cold agglutination test. In streptococcal Mg test, you make serial dilutions of patient serum to which you add heat fixed or heat killed suspension of streptococcal Mg. So if the patient's serum is having antibody, it binds to the streptococcal Mg antigen and it shows agglutination after you incubate at 37 degrees centigrade. Coming to cold agglutination tests, here the serial dilutions of patient serum are incubated with human O blood group RBCs, and they're incubated at 4 degrees centigrade. That's why it's known as cold agglutination. They only agglutinate at 4 degrees centigrade. So, but cold agglutinants are found only in 60 to 65% of patients. So they can be false negative tests sometimes, and false positive test is seen in infectious mononucleosis like Epstein-Barr virus infection, cytomegalovirus infection, adenovirus infection. Okay, but the best test as discussed is a molecular method, polymerase chain reaction targeting Mycoplasma pneumoniae specific 16S ribosomal RNA and P1 adenosine gene. So that was about the diagnosis. Now let us look into the treatment. Usually this disease is self-limiting, but in certain cases you need to use antibiotics like protein synthesis inhibitors or nucleic acid synthesis inhibitors. You should not use cell wall inhibitors because it lacks cell wall. So drugs of choice are tetracycline and macrolides, and respiratory quinolones like levofloxacin, moxifloxacin and gemifloxacin. So that was about Mycoplasma pneumoniae, a respiratory tract pathogen. Now let us move on to the urogenital mycoplasma. So urogenital mycoplasma is caused by Mycoplasma hominis, Mycoplasma genitalium, and also by Ureaplasma urealyticum. These pathogens usually colonize the vagina, cervix and periurethral area of the females. So how are they transmitted? They're transmitted by sexual contact, or they're transmitted from mother to fetus during delivery. So what are the clinical manifestations they produce? Mycoplasma genitalium causes non-gonococcal urethritis and pelvic inflammatory disease. Mycoplasma hominis causes pyelonephritis, postpartum fever and some systemic manifestations like meningitis and wound infections. Ureaplasma urealyticum is causing non-gonococcal urethritis, pyelonephritis, urinary caliculi, premature delivery and spontaneous abortions. It can also cause chorioamnionitis, endometritis, etc. So now what is this non-gonococcal urethritis? Usually when we talk about urethritis, we remember that it's caused by Neisseria gonorrhoeae. So whatever urethritis caused by Neisseria gonorrhoeae is known as gonococcal urethritis. Urethritis caused by other pathogens other than Neisseria gonorrhoeae is known as non-gonococcal urethritis. So Mycoplasma genitalium and Ureaplasma urealyticum are causes of non-gonococcal urethritis. Now how do you diagnose? So the sample will be either vaginal swab, cervical swab, urine or semen, and the processing is by culture and PCR. Culture we have already discussed the media, but how does a colony look on the agar? Mycoplasma hominis colony has a fried egg appearance. Why fried egg? Because there is a central granular opacity surrounded by a flat translucent peripheral zone. Okay, so that's you can see in the picture here the fried egg colony. It's better appreciated by dye staining. Coming to ureaplasma, they're very tiny colonies, very small, 15 to 50 microns. You need a microscope to see them. They're better demonstrated by dye staining. Okay, so in dye staining, the mycoplasma has a blue color, whereas ureaplasma is having reddish to greenish blue color. You can see in this picture the fried egg appearance, central granular opacity and the peripheral translucent zone, flat and translucent periphery. So other methods of identification is inhibition of growth by specific antisera, arginine utilization by Mycoplasma hominis, and urea hydrolysis by ureaplasma. This is the way we identify the species. But the best test is PCR, which is sensitive and specific method. And what is the treatment line? Macrolides like erythromycin or azithromycin are used for ureaplasma and Mycoplasma genitalium infections. Ureaplasma is usually resistant to tetracyclines. And drug of choice for Mycoplasma hominis is clindamycin. So now the new term we learned was non-gonococcal urethritis. So what are the other two agents apart from Mycoplasma genitalium and ureaplasma urealyticum which cause non-gonococcal urethritis? They are Chlamydia trachomatis and Trichomonas vaginalis are two other agents. It's a very important short notes. You have to know at least list 4 of the causative agents of non-gonococcal urethritis. So please try to attempt these questions. They are very important short notes, frequently given in exams. Dyne's method, Dyne staining, cold agglutination test, list some agents of atypical pneumonia and list the agents of non-gonococcal urethritis. So I hope it was clear, students. So that was the class for today. Thank you very much.